Assalamu alaikum, everybody. I welcome all the audience from all around the world to today's webinar organized by Imamia Medics International Academic Council. I would like to introduce myself first. My name is Simreen Fatma, and I am associated with IMI International Academic Council as Academic Coordinator. Today, I have my co-host Dr. Kiran Ijaz in this session. She is from US and has been associated with IMI International Academic Council for past 8 years. Welcome, Dr. Kiran.
Assalamu alaikum, everyone.
Walaikum Assalam. It has been a tradition of IMI International Academic Council to hold sessions on different health related topics. This session is one of the continuation of the series. Today, we have highly qualified clinical professionals with us to discuss on the topic of allergy and asthma awareness. This session will include awareness about this disease. Our first speaker is Dr. Naveed Sheikh. Dr. Naveed is a graduate of Allama Iqbal Medical College, Lahore, Pakistan. He completed his further education in US and served as Director of Pulmonary and Critical Care Medicine at Oak Ridge, Tennessee. Currently, he is practicing critical care medicine and interventional pulmonology in Georgia, USA. Our following speaker will be Dr. Rana Ali. She is an assistant professor of medicine teaching at multiple medical institutions in New Jersey. She is currently serving as Fellowship Program Director at Ocean University Medical Center. She has been practicing pulmonary and sleep medicine since past 20 years. Now I would hand over the session to Dr. Naveed. Welcome, Dr. Naveed. Over to you.
Thank you. Assalamu alaikum, everyone. Next slide, please. So we'll start with defining what is asthma. Asthma is a breathing problem which is characterized by episodes of shortness of breath or breathlessness intermittently with wheezing, which is whistling breath sounds, cough, some chest tightness, and inability to exercise. In severe cases, it can be life-threatening, and it can be diagnosed at any age, as a child, as an adult, or elderly. It is a chronic problem which is not curable, but it can be controlled with medication with a goal for the patient to live as normal as possible and able to continue daily activities. Next slide, please. Talking about how common this disease is, in 2021, approximately 7.7% of people in the United States had a diagnosis of asthma, which makes it approximately 25 million. As compared to 2001, there was an increase noted. In 2001, approximately 7.4% people, which is approximately 23 million people, were known to have asthma in the United States. Among children under 18, asthma rates were slightly lower at 6.6 compared with 8% in adults. These statistics are from CDC. Next slide, please. According to the global burden of disease, asthma-related deaths worldwide are approximately 420,000 per year. But the number of asthma-related deaths are declining as over the period of year and decades. And annual death rate from asthma in the United States is around 2,000 per year. So prevalence of asthma is increasing, but a number of deaths related to asthma are coming down, probably because of more awareness and availability of different treatment options. Next slide. Next slide. So talking about what actually happened in asthma attack, on this picture on the left side, normal airway is predicted. On the right side, an airway during the asthma flare is predicted. The normal airway is like a tube which is open and air can move in and out of the lung and people can breathe. When asthma is flared or triggered, the side of the airways become more inflamed or swollen, and the muscle around the airway becomes constricted or tightened. That leads to less room for the air to move in and out. And in a severe case, it can shut down, leading to respiratory failure and even death. Next slide. Talking about risk factors for developing asthma, there are risk factors even before birth, during pregnancy. Vitamin D deficiency in mother is associated with wheezing early in life, but not long term asthma. Active smoking by mother or exposure to tobacco smoke, even secondhand, is associated with asthma in newborns. Certain diet in mothers, such as processed meats, artificial sweeteners, etc., are also noted to be a risk factor. Some medication utilized during pregnancy, such as Tylenol, acetaminophen, acid suppression medication, and antibiotics, are also associated with childhood asthma. After the birth, if the birth is premature, infant has jaundice, mode of delivery was C-section, they are associated with high risk of asthma in children. Breastfeeding reduces the risk of asthma in the first couple of years. Next slide. During childhood, female have more. They are more prone to have asthma, but as the age progresses and after puberty, males are more prone to have asthma, and prevalence is more in men than women. Allergies, skin inflammation, dermatitis, eczema, they are associated with asthma. In such cases, there are cell count or a blood test called immune globulin E that can be checked, and sometimes it can be high in people. Exposure to allergens such as house dust mite, funguses, cockroaches, indoor animals such as cat, dogs, farm animals, sheep, etc., may also be associated with childhood asthma. Recurrent bacterial viral infections, recurrent respiratory infection are also independent risk factor for children to develop asthma. Next slide, please. Again, the certain medications such as acetaminophen, ibuprofen, antibiotics are associated with asthma. Outdoor air population, indoor population pollution, sorry, such as fire furnaces, wood stove, chemicals. They are risk factor for asthma, obesity, and early puberty, especially in the girls, are is a risk factor. Next slide, please. In adolescence and adulthood, obesity, active and secondhand cigarette smoke exposure, occupational exposures, chemicals for industrial spills, upper airway inflammations, they're associated with asthma, postmenopausal hormone replacement therapies, and independent risk factor. Next slide, please. So there are different types of asthma, and there are different ways how we can categorize asthma. One way is childhood onset asthma. Many children outgrow this during early adulthood, but in some cases, symptoms may return during later in the life. Then adult onset asthma. Next slide. Asthma can also be put in the categories depending upon the symptoms, like mild, moderate, severe. I will skip this slide as Dr. Rana, who will be presenting the treatment of asthma, has more in-depth analysis on that. Next slide, please. Before we talk about this slide, there's another type of asthma, exercise-induced asthma. When people exercise, they have their own body secrete certain hormones that protect towards wheezing and asthma attack. But when they stop exercising, a few minutes later, due to withdrawal of those chemicals and hormones, they start developing wheezing. So it's a little misnomer. A misnomer. A lot of people think that they're short of breath during the exercise, and that's asthma. But generally, exercise-induced asthma hits after they stop exercising. Now, coming to this slide, types of asthma by inflammation. We can categorize them type 2, non-type 2, and complex patients. Type 2 asthma is associated with inflammation such as high cell counts in the blood, inflammatory components. In these patients, they can have positive blood and skin allergy testing. There's a type of inflammation that is triggered by aspirin inflammation. Again, Dr. Rana has a more in-depth slide on that. I will skip on that. Next slide, please. Non-type 2 asthma, such as obesity-associated perimenopausal and complex, as I mentioned, overlapping type 1 and 2 asthma. Next slide. The diagnosis of asthma, it's a clinical diagnosis. We start generally with history taking about the symptoms on examination. If asthma is triggered and flared, we may or may not hear wheezing, nasal polyps, other signs of inflammation. For support, we can do some testing such as complete blood count for certain blood types like eosinophils, immune globulin levels, sputum test, some markers of inflammation. But there is no X-ray, CT scan, blood test, or any test that we can do and that spills out the diagnosis of asthma. It's mostly clinical. We can do a pulmonary function test, which measure the lung function. We can also see how some people respond to inhalers. We can check FeNO, which is nitrous oxide, and higher levels are associated for the flare up of asthma and more associated with type 2 asthma. There's only one test that we can do to rule out asthma. It's called challenge test with methacholine or cold air. When people are exposed to the cold air or methacholine or similar chemicals, they can develop wheezing. If they don't develop wheezing or their lung function do not drop, it can reliably rule out asthma. But if they test positive on that, then even normal people can have a response to these people. So it has more value when it's negative. Next slide, please. From this point onwards, I would invite Dr. Rana Ali to take over the management part of the asthma. Thank you so much for listening.
Thank you, Dr. Sheikh, for this comprehensive discussion on asthma. We'll dive straight into the management and then take the questions at the end of the discussion. As far as the treatment of asthma goes, the most important thing is basically to know your triggers, have an action plan, talk to your health care provider and follow up the treatment, and then prevention of future attacks and future exacerbations. Next, please. The asthma control evaluation becomes very important. As Dr. Sheikh just pointed out, you know the symptoms of asthma, you know the triggers for asthma. Now you have to evaluate how your symptoms are. The symptoms could be cough, shortness of breath, chest tightness, wheezing, any of those. And then how to evaluate the severity. You have to assess that over a 4-week period. If you have too much of daytime symptoms more than twice a week, if you have any nighttime awakenings because of asthma, if you're using, how often you're using your rescue inhaler or short acting that we will be talking about later on, and if there is any activity limitation secondary to asthma. Now, if you have none of those, your symptoms are well controlled and continue doing what you are. If you have 1 or 2 of these positive, you have a partially controlled asthma, and you may want to talk to your healthcare provider should there be any addition of medications. And if you have 3 or 4 of these symptoms, your asthma not controlled, and you need to see your healthcare provider and adjust your medications. Next, please. Next slide. So the management of asthma gears towards 2 things: improving the symptoms and lung functions, and then reducing your future exacerbations, reducing the use of rescue medication, reducing the frequent emergency visits. The management of asthma is a very cohesive work that is almost like a partnership between the healthcare provider and the patient and how to adjust your medications. Next, please. From apart from knowing your symptoms and diagnosing asthma, like Dr. Sheikh mentioned, with pulmonary function tests and nitric oxide exhalation and stuff, we can also do a peak flow monitoring. Now, I am always wary of advising peak flow monitoring because everybody's life then revolves around the peak flow monitoring. People come in with 3 pages of like peak flows documented 5 times a day and multiple phone calls. Please don't do that. The peak flow monitoring comes into effect. It should be short term. It should be to differentiate the symptoms of asthma that could be from a lot of other things. Heart disease can have shortness of breath and breathlessness when you are exerting. Something else may be causing the cough, hundreds of causes of cough, right? It may not be all asthma. And in those situations, you can do your peak flow monitoring. It is also effective in differentiating occupational or domestic triggers that is giving you the symptoms and you may not know about it. Next, please. The peak flow, again, one important thing when we are monitoring peak flow for a patient is basically to measure your personal best. Please don't check your peak flow with your neighbor or your best friend who may be 6 feet tall and 25 years of age, because his is going to be much better than yours. Know your personal best. That means when you are feeling the best, you do your peak flow. And then when you're not feeling the same, you actually try to do the peak flow again. If your number is 80% of your personal best, at 80% and above of your personal best, you're good. You don't have any significant bronchospasm. If it is anywhere between 50 to 80%, you may want to kind of keep an eye on it and adjust your medication. If it is less than 50%, you have significant bronchospasm and you need to take your inhaler and contact your healthcare provider for adjustment of medication. Please be wary of the fact that peak flow monitoring and peak flow usage is very personal, dependent on the user. If you don't blow in hard enough, you will have a low peak flow at that time. Next slide, please. So the treatment of asthma now depends on rescuers or the relievers and preventers. How does the rescue medicine work? It just, as Dr. Naveed very well pointed out, you have chronic inflammation in the airways. Your airways are narrow. You need to give something that relaxes the airways, open it up so you can breathe better. You reduce the acute symptoms of cough and shortness of breath. And for that, you have inhalers available. We'll talk about it in a bit. Then there are preventers. We are preventing this chronic inflammation in the lungs. Asthma is an inflammatory condition. There is persistent inflammation in the airways, and your airways are narrow. And because you need to decrease this swelling, and that is what your preventers do. You need to have a long-term plan to prevent these future episodes. And for that, there is a different kind of medicines that's available. Next, please. The type of treatment, along with just the inhalers, are antihistamines. As it was pointed out earlier in this discussion, there is a allergy component to it. You can have leukotriene modifiers that's available, which is montelukast. You have something that acts on the immune system, the IgE, because IgE is again one of the chemicals that actually helps to release these inflammatory markers in the lungs and causes airway spasm or bronchospasm. And those are injectables. Then you have the biologics. Now, the biologics are gaining a lot of press these days. They are injectables which are available. Multiple different biologics are coming in, and they can be used as an add-on treatment in people who have allergic asthma. Then you have immunotherapy with the allergist use. It could be injections, it could be sublingual. You target a particular allergen and you kind of desensitize your body to these allergens. Oral steroids a big thing for us, and our goal is to prevent the use of oral steroids on a chronic basis. And then there is something called as bronchial thermoplasty, which is definitely out of scope of this lecture. It is basically an invasive procedure which is done to kind of provide heat to the airways and thereby decreasing or changing the thickness of the airways and keeping it more open. This is all in severe asthma. And it's not a first-line treatment for anyone. Next, please. This is the slide that I borrowed from Dr. Sheikh. It actually tells you the different severity of asthma, anywhere between intermittent, where your symptoms are less than twice a week. Your nighttime symptoms are less than 2 times a month. You are using your inhaler less than twice a week. In that case, your pulmonary function tests are essentially unremarkable and normal, and you can continue the use of your rescue inhaler on an as-needed basis. Then there are persistent symptoms, which are mild, moderate, or severe, depending on how often you are actually exhibiting the symptoms of asthma, be it nighttime awakening, be it shortness of breath or wheezing, be it bouts of cough. There is also something called as a cough variant asthma, where bronchospasm or airway narrowing can present like cough. And in these patients, as we move towards the right side of the chart, you can see the lung functions are kind of declining. And this is when you start using different medications. Next slide, please. This is a busy slide. I don't want you to read through it, but this is basically showing you a stepwise approach to the treatment of asthma. As I said, if your symptoms are controlled, use your inhaler on an as-needed basis. As you progress with your symptoms, as your lung functions decline, we have options of adding on to different medicine. As far as the as-needed inhaler is concerned, the guidelines have changed recently. It used to be albuterol. Now, as we know, the asthma is more of an inflammatory condition. We do need an anti-inflammatory, and that is a combination of an inhaled steroid along with the albuterol. Please don't be wary of the use of inhaled steroid. It does not have all the side effects of an oral steroid that we try to avoid as the disease progresses or as the symptoms worsen. If you look at the last step, you see we have a lot of options, and these are the options that we had discussed before. It is a long-acting form of albuterol along with steroid. We can add another inhaler, which is available in the market. We call them LAMA. It's like Spiriva at a low dose. You can get injectables, both anti-IgE like Xolair, or different biologics, which are Fasenra, Dupixent, Tezspire. Every time you turn on the TV, you see an ad of that. And yes, those are very effective in patients who have an allergic component or eosinophilic component that Dr. Sheikh had mentioned before. That is like becoming more and more prevalent. You can also add oral steroids, but they should be used mainly during an acute attack or an exacerbation. Next slide, please. This is all that is available in the market. It's overwhelming. Every time you look around, there is a new inhaler. The choice of the inhaler, as you can see, there are different categories, is something that your healthcare provider and you decide on. And what brand you go in, unfortunately, half of the time is directed by the insurance coverage and what you can afford. If you look at the last line of this, that's where your injectables come in, and then you have the option of the bronchial thermoplasty. Next slide. So the treatment plan for asthma, the most important thing is trigger avoidance. Know your triggers, avoid your triggers. Maintaining a healthy diet of an anti-inflammatory food. Now, I'm not a nutritionist, but it is very important. The food which have antioxidants definitely work. Vitamin D, omega-3 fatty acids have shown to be actually effective because the deficiency can actually lead to worsening symptoms of asthma. Now, exercise and asthma is a myth. Yes, you should exercise because regular exercise is important for your heart health and also for the lungs. Management of stress. Stress is actually a known factor that can worsen the symptoms of asthma, both objectively and subjectively. The more you panic, the more you pant, the more difficult it is for you to exhale all that air you have inhaled in, and it can worsen your symptoms of asthma. Sleep is very important. Lack of sleep, again, increases the inflammation in the in your body, and that can actually cause the worsening symptoms of asthma. Weight management, we'll talk about it a little bit later. Weight loss certainly helps. I'm a huge advocate of vaccination. Decrease the respiratory illnesses, please. Every time you develop a respiratory illness, you do cause some damage to the lungs and worsening lung functions. Use the inhaler properly. It is very easy for us to write for inhalers. Unless you know how to use it, it's difficult. When you take an inhaler, a puffer, you are actually getting only 40% of the medication into your lungs, no matter how good a technique you use. If you are not using a good technique, barely anything is going into your lungs, and your lung functions are not going to improve. Asthma action plan, as we talked about before, is important. Talk to your healthcare provider and do it. And then, of course, keep a good home environment. That is important. A clean house to decrease your allergens. Next, please. I'm briefly going to touch on certain conditions that could make asthma worse, pregnancy being one of them. Pregnancy has shown to be an independent risk factors for asthma exacerbation. If you look at the literature, 30% of patients during pregnancy get better with asthma, 30% stay the same, and 30% get worse. The symptoms of asthma gets worse in pregnancy could be a lot of reasons for that. One of them is just simple acid reflux. The reflux of acid can cause airway spasm. It could be the weight gain that is preventing your lungs from expanding, and medication non-compliance because you're not focused on yourself at that time. Next. During pregnancy, it is very, very important to treat yourself. Use the inhaled steroid with the bronchodilator during pregnancy. It is good for you. It's good for the baby. If your diagnosis of asthma has not been objectively, that means with a breathing test established, continue the use of inhaler as per your healthcare provider. And then after the delivery, you can have those confirmatory tests. But please do not ignore the treatment of asthma during pregnancy. Next, please. Aspirin exacerbated respiratory disease, very common. It's about, the prevalence is almost 7% in the adult population. The bronchospasm after taking aspirin normally occurs between 20 minutes to 3 hours. Most of the time, patients have nasal polyps or nasal symptoms with it, nasal congestion, excessive mucus production, and all that stuff. And it is important to identify this. Now, this does not mean that if you need aspirin for your cardiovascular disease, heart, stroke, whatever, you need to have aspirin desensitization and not just stop this aspirin blindly. Next, please. Exercise-induced bronchospasm, as Dr. Sheikh just mentioned, is important. The symptoms happen 10 to 15 minutes after exercise or during prolonged exercise. We see that often in young athletes. And the treatment is to actually either a leukotriene receptor antagonist like montelukast, or you use your inhaler 5 to 10 minutes prior to your exercise. But please don't use this as an excuse not to exercise. It is important. Regular physical activity, that is the latest guidelines by from Asthma Society. Regular physical activities improve the cardiopulmonary fitness and certainly has been advised. Please don't push yourself if you're really short of breath. Next. Obesity. Very important factor, independent factor for asthma. A 5 to 10% weight loss has shown to improve asthma control and quality of life. Patients who are obese and have sleep apnea, the use of CPAP therapy has shown to cause reduction in the exacerbations over a 6-month period with compliance to the CPAP use. Next. Then comes occupational asthma. This can account for about 50 to 20% cases of asthma per se. This is also called as reactive airway dysfunction syndrome or irritant-induced asthma. Your symptoms are great when you're on holidays or you're at home, but when you go to work, you start having the symptoms. Please don't use this as an excuse not to work. Not every shortness of breath is related to asthma, but this is where your peak flow monitoring comes in handy, and also the fact that your history, your symptoms are getting worse, and what you can do about it. Next, please. Any kind of occupation can cause it. If you can read through this, anything, any airborne chemical, any particulate matter, any strong odors, hairdressers develop this a lot. So anything can cause sensitivity to your airways and can cause asthma. Next, please. The one thing I would want you guys to know or to take from our presentation today is know your triggers. Avoid your triggers. That is the most important thing. Allergy seasons with pollen, chemicals and fumes, just cold air. When you go out in the winter months, use a scarf around your face. Avoid that hit of cold air through your nasal passages because that will lead to bronchospasm. Mold, dust, strong odor, stress. Reduction of stress has definitely shown to have improved asthma. And of course, exercise. Do what you can, but certainly do not stop exercising. Take your inhalers and go for it. Next. Thank you all for giving me the opportunity to speak. We are open for any questions you have.
So I would like
Okay,
to pay.
everyone. For the Q&A session, I'll request the audience to actually use the chat option or the raise the hand option. Is available at the bottom of your screen or of your devices. While you're trying to type in more questions, I have a few already in the chat. So the first question to our speakers is what is the role of air pollution in triggering asthma?
So there was a slide that I included about the air pollution as an independent risk factor. So just think about it. If you something that goes in your lung which doesn't belong there is a risk factor. That could be pollution, dust, industrial pollution, smoke, any fumes, chemicals. Petroleum fumes. A lot of people work in the petroleum industry. So that is an independent risk factor for developing asthma and the flare up of asthma.
Would you like to add anything, Dr. Rana?
No, as Dr. Sheikh said, and that's what our previous slides were showing, air pollution is important, not just the fumes and stuff, but the particulate matter. The size of the particles that you're inhaling is causing constant irritation through your nasal passages all the way into the lungs. And that actually increases your inflammation. As we had mentioned before, this is an inflammatory condition, and anything that increases irritation and inflammation is going to trigger your asthma. So it's very, very important to keep your surroundings less polluted if you can, and allergen free.
Great. Our audience is from around the world. So, are there any suggestions for people who, like, in the petroleum industry, it's their work? So, any precautions that would like to share with them?
I always tell the patients if they are at a risk of inhalation, use a mask. It's uncool, but use it. Like if you are a carpenter and you're actually using, using a saw and there is a lot of sawdust coming in, it is going to cause irritation. It is going to cause symptoms. Use a mask. Use those respirators that are available. Like in the US, I know it's available at Home Depot and stuff. Elsewhere, if nothing else, put a scarf around your face, and that would be the best thing. At home, keep your environment clean. People can use a air purifier or a humidifier. I'm not against it, but definitely pollution and dust will make your asthma worse.
Great. Now that you mentioned the air purifier indoors, what about the indoor asthma triggers, especially in the US when the house is always air conditioned, closed, and our type of cooking actually generates more smoke? So, what's the insight about that?
Good ventilation definitely helps. You have to have ventilation in the house. Now, do keep in mind when you open your windows during spring or fall, you will have all these pollen and allergies coming in. So you have to be careful about that. But the one thing that is important is dust, right? Sometimes for our severe asthmatics, we do tell them to use mattress covers, down comforters that we are all used to using during the winter month can cause worsening asthma symptoms. So avoid that. As I said, know your triggers. If you feel that using a down comforter is going to give you a bronchospasm, don't use it. And then mattress covers and vacuuming your home as often as you can is important. Pets, very important. Cat and dog dander are a significant have significant risk of airway inflammation. So don't let your pets come and sleep with you in the same bed. If they do come into your room, vacuum your sleeping area as often as you can. Dr. Sheikh, if you have anything else to add, please.
Well, I think there, with the central air conditioning, there's some a little bit of filtration for the larger particles, but there are home filtration system available that you can use. Of course, it costs a lot of money, but I think common sense things, keeping your living space clean is the most important thing. Of course, I mean, we cannot control the everything in our environment. We, especially if you live in South, you're exposed to a lot of pollen and allergens. So I think we all just need to do our best and see how things go. Unfortunately, we cannot control everything. And there comes the preventive inhalers, the maintenance inhalers. That, if you live in South and you're allergic to pollen, and you need to live in that area, then you need to be on maintenance medications.
Great, thank you so much. Our next question is any early prevention recommendation for cold or infection-induced asthma?
Dr. Ali actually mentioned about the vaccination, which is very important. So make sure that everybody's up to date on vaccination. Flu shot is every day. If you qualify, pneumovax. If you are exposed to somebody, if you are sick and you have viral illness, make sure that you take appropriate precautions. And if you are around people who are sick, make sure that you don't put yourself in undue harm. If they're coughing, don't stay in the straight line of action. Wear a mask, wash your hands frequently. So these are all to prevent the colds and infections, especially the viral illnesses in the upper respiratory tract, flu, COVID now. But if you cannot control that, and Muharram is around the corner, and you're in the majlis and you get exposed and you develop sickness, and then make sure that you get appropriate health when necessary. Sometimes if you're wheezing and you're short of breath, you might need treatment for the flare up. Many times people develop superimposed bacterial infection on top of the viral illness. So not you don't need antibiotics for viral disease, but if you develop superimposed bacterial infection, then you may need antibiotics, some steroids. Make sure that you are on maintenance inhalers and using your rescue inhaler on as needed basis.
Excellent. Our next question is, what is the role of family history and genetics in risk of developing asthma?
So, family history definitely plays a role. If one of your parents or both of them have asthma, you have siblings with asthma, then you're at risk of developing asthma more than other people. Also, it depends upon the how you're responding to the factors in the environment. Sometimes you have genetic predisposition, and then you develop certain recurrent viral infections that trigger some T cell inflammation, and it changes your system. And as Dr. Ali mentioned, that every time you have a respiratory illness, there is some damage to the lung. And with a recurrent, if some people develop asthmatic bronchitis, but if you have recurrent lung infections and recurrent triggers of wheezing, then you can develop just like any other muscle. If you use your biceps a lot, you get bigger and thicker biceps. Similarly, if your respiratory muscles, which has smooth muscle in it, it contracts much more recurrently with the wheezing. It can get thick and hypertrophic, and you can have chronic um, uh, airflow obstruction. Long story short, yes, the family history and genetics do play a role, put you at high risk.
Perfect, perfect. So our next question is with regards to aspirin desensitization, and it's coming from our cardiologist, Dr. Shahryar Hedri. So the question is, I have patients with asthma, with aspirin allergy, or maybe aspirin-induced asthma. Is there a standard protocol that PCPs or cardiologists can start with patients, or should it be done by allergy specialists?
Yeah, that's an important question, Dr. Scherer. I think I personally have not done aspirin sensitization even myself because sometimes these attacks could be way more than what we anticipate. You know, they have um, I normally refer a patient to an allergist, and they have had success. And a lot of patients have had a successful desensitization because I know as a cardiologist, you have a lot of patients, you want them to be on aspirin for stroke prevention, for coronary artery disease. And these patients need to be desensitized. That is the recommendation. Small doses of aspirin, and then they can be on full dose of aspirin after all. But afterwards, once the desensitization is done, but they have to continue the use of aspirin thereafter. So it is important. I would refer the patients to an allergist to get it done.
Okay. Would you like to add anything, Dr. Sheikh?
No, I think she was pretty comprehensive.
That's good. So, Dr. Rana, in continuation to this, can you shed some light about the immunotherapy treatment that you just spoke about? Is it supposed to be at a doctor's office only, or sublinguals can be given at home for pediatric age group?
So, immunotherapy is normally something that we are targeting a particular allergen, right? Like
Mm-hmm.
there are some sublingual medications available, there are injectables that are available, and most of the time, the allergist immunologists are the ones who do it. The other options that we as, and Dr. Sheikh, if you have anything different to add, please go ahead. The one that we as pulmonologists do is basically your anti-IgE, that is the Xolair, or your biologics like that are available now in the market. And it can be taken two ways. Of course, there are pre-filled syringes that the patients actually take it at home, and the risk of reaction, particularly like a full blown reaction that we call as anaphylaxis, is very, very small. The first dose always should be monitored. So it's either taken in the doctor's office or you have a nurse coming to your home and give it, depending on your insurances. And then it can be taken at a home. The biologics that are available right now, which actually target these chemicals called as interleukins and stuff, they are not available sublingual at this time. It is mainly the immunotherapy that the allergists give. I personally have not prescribed immunotherapy because the allergists and the immunologists do it. Dr. Sheikh, if you have anything different to add on that.
No, I second your everything here that you said. Our office is also not set up for immune modulation therapy, but basically it is injecting the small quantity of allergen, triggering your own immune system to develop components in the blood that can fight that allergen, and slowly increasing the dose to a point that the body is already ready to fight it off. And it generally starts with the more frequently, then go less frequently, every 2 weeks, maybe a month, and then sometimes people are able to stop it. One more thing I like to add here is people who have allergic component of asthma, immune modulation therapy and trigger avoidance has great response. In some cases, I have combined immune modulation therapy and these biological agents together, and with the good response. If I go like 5, 8, 10 years ago, a lot of our patients were on chronic steroids, and now with all those things changing, people more open to use these medications, give themselves injection at home. I have very few patients left on high dose chronic steroid therapy. And one more thing with this biological and all those management strategies, Dr. Ali mentioned briefly about bronchial thermoplasty. In short, it is basically with the bronchoscope endoscopy of the lung, you can heat up the inside of the lung um, to to modulate the muscles of the lung, which are getting thicker, so that they don't get any further thick. But with these changes, bronchial thermoplasty is pretty much obsolete now.
Great. The next question is, are there racial differences in susceptibility to asthma? Also, any difference in response to medications between racial groups?
So blacks and Hispanics have more prevalence of asthma, but as far as the treatment strategy is concerned, it's the same.
Okay. Um, do you prescribe exercise, rehab, or stress management for your patients with asthma? Any dietary advice for prevention?
So many times, if I suspect allergic component of asthma, then I check the blood for uh, IgE specifically for certain foods. There are different allergy panel depending upon where you live, so food particle. So I do have many patients who have elevated IgE against certain component of, let's say, egg or milk or beef. So in these cases, depending upon their symptoms, I mean, if they are very well controlled asthmatics, I don't do much about it. I don't tell them to avoid that food. But if their asthma is triggered by these foods, then I tell them to avoid that. And in some cases, if the symptoms are very severe, they need immune modulation therapy.
Uh, So, while we're talking about allergy testing, would you like to speak a little bit about how allergy testing has modified over the years. Now it is like more in the blood or through skin testing rather than, you know, how in the past patients were terrified about subcutaneous injections. Uh, so would you like to share some light on that, please? Open to both the speakers, please.
So, allergy skin testing and allergy management is basically a little beyond the scope of pulmonologists. There are other specialists called allergy and immunology specialists who deal with this. But briefly, from a pulmonary standpoint, there are pulmonary offices where they equipped to do skin prick test. I don't do it. I'm not sure if Dr. Ali's office is equipped to do it, but I generally do the blood testing. And blood testing, if it is abnormal, it does not necessarily mean that they have to avoid every single thing. I have patients they have elevated IgE to cockroaches, dust mites, wheat, egg, milk, hickory, this grass and that grass. So you look at them, their testing is lighting up like a Christmas tree. So if you tell them to avoid all of that, it is practically impossible. They have to move to Mars to do that. Um, but but in some cases, they do need immune modulation therapy. I send them to allergists for that. Um, but I'm pretty sure there are some pulmonary offices who do the desensitization by themselves. Dr. Ali, do you have anything to add?
No, no, just to add on to what you said, absolutely. We also just send the patient for blood work. It's much simpler. Every area has its own zone. It's called as RAST, RAST. I still don't know what it stands for, but that's what we do for different zones. I also send the patients for for eosinophil levels. So if your eosinophil level is high, then as we had mentioned before, we have these options of the biologics. So these injections that we are giving, all these that are available in the market, the Xolair, not Xolair, sorry, the Fasenra, the Dupixent, the Tezspire, and all that stuff, they target the chemicals in the brain in the blood that actually causes or prevents the release of histamine and the inflammatory markers and decreases the inflammation. So these patients do very well on the biologics. Same thing if their overall IgE level, not just the specific for a particular allergen, but overall is increased, then we have the option of Xolair or other basically the anti-IgE medications. So the treatment of asthma, as Dr. Sheikh had mentioned, has certainly evolved over the past 10 years. It is not oral steroids long term. We are all trying to avoid that, and by the addition of all these additional medications.
Great. The next question is, if known asthma triggers cannot be avoided, do you recommend inhaler or oral medications before any asthma symptoms begin?
Go ahead.
No, please, after. Go ahead, Dr. Sheikh.
So it depends upon the asthma trigger. I mean, if you're talking about exercise as the asthma trigger, then I think Dr. Ali has covered that already. Take medication before doing exercise. But what are the other asthma triggers? For example, somebody is, let's say, housekeeper and have to deal with cleaning agents and have asthma, and that triggers the asthma. Then we see it very common in occupational exposures as well. So it gets very difficult because uh, if that's the only thing that they can do and that's the only skill they have and they cannot change their job, then you have to control it with maintenance inhalers, inhale corticosteroids. They may need a rescue inhaler such as albuterol before getting exposed to these things. They may have to wear a simple mask or maybe a respirator. Coming down to the respirator, I mean, usual population was introduced to respirator or N95 mask in 2020 after the COVID hit. I'm pretty sure that most of the people wouldn't even know what is N95 before that. But OSHA and occupational agency has that indeed introduced a lot before general population. And Home Depot was the place where you would get respirator or N95 mask, and you still can get these equipment from there. So again, if we stick with the basic idea, avoidance of the trigger, rescue inhaler, maintenance inhaler, and if you develop complications such as flare, get that treated. Don't let it go. So these are the basic ideas. That trigger could be exercise, could be allergies, could be respiratory infection, any such thing.
Okay. The next question is about how can respiratory infections worsen asthma symptoms?
So as any URI or respiratory infection leads to inflammation and inflammatory cells triggering the thickening of the submucosal glands and muscles, and that leads to asthma flare.
Okay, so among the menu of drugs available now, are there some preventing progression of disease rather than just relieving of symptoms? Which ones are those and how expensive are they?
I think Dr. Rana actually went over in detail. So if Dr. Ali, if you don't mind, I'll take
Sure,
that one. We have already
sure,
done
sure.
that.
Yeah,
So if I have to categorize the medication into two big categories, one is rescue medication, and the other one is maintenance medication. So rescue medications such as albuterol is the one people are most commonly aware of. If you are going to be exposed to your usual trigger, for example, cold air, exercise, or whatever, or if you're already wheezing or you're short of breath or you're coughing, you take a couple of puffs of albuterol. So it's a reliever medication, or more commonly it's called rescue inhaler. The other category is maintenance medication, which are used to prevent you getting to a point that you are using the rescue inhaler. These are inhaled steroid medications, a combination of inhaled steroid and long-acting beta agonist, or just say, think about it, a long-acting albuterol, a combination of inhaled steroid and long-acting muscle relaxant. And sometimes we add medication like Singlet or Montelukast. Sometimes which are leukotriene inhibitors, and sometimes we add other medications to deal with stuff around the lung as well. For example, if somebody has acid reflux, which is uncontrolled, it is triggering asthma, then you have to be on acid suppression medication. If you have upper airway inflammation from whatever you're exposed to, sometimes you need to take nasal sprays and allergy medications. So, in a bigger term, rescue medication, maintenance of preventive medicine, that can be inhaler, that can be allergy medication, that can be biological agents, or whatever. As far as the cost is concerned, as Dr. Ali pointed out, that unfortunately we live in a place where our practices are dictated a lot by the insurances. So just think about it. If you have mild asthma, your first step is inhale corticosteroids, then you go to a combination of two medications, then you go on the combination of three medications. Depending upon what insurance you have, what coverage you have, it may cost you $0 or $700.
very true. So for the maintenance therapy, I'll just add on, I always tell the patients, for maintenance therapy is like an aspirin to your heart. You don't want to wait for a heart attack to take aspirin. You take aspirin to prevent it. And that is what we try to do with the maintenance therapy, is to prevent these exacerbations, prevent these attacks of asthma. And our goal is to like kind of control the symptoms and control these future attacks.
Okay. Dr. Kayumi shared that RAST, RAST, is regional allergy testing.
Thank you, Dr. Kayumi. Can you imagine after 20 years, I never looked that up? Thank you.
All right. So, and the next question is how to deal with onset or acute allergy reactions, any medicines of any medicine or something.
So, acute allergy, um, the symptoms could range anywhere from just maybe a little runny nose to the skin rash, all the way to lip swelling, airway swelling that may block the airway, leading to death, or even anaphylactic shock when all that inflammation leads to blood vessels giving out and the blood pooling down and not circulating, so it can lead to shock and even death. So depending upon what spectrum we are talking about, it could be just avoidance of the allergen to taking a short-acting allergy medication such as Benadryl, or be on a long-acting medication such as loratadine, fexofenadine, which is generic Allegra, Zyrtec, or combination of that. Sometimes people are on Montelukast, which is leukotriene inhibitor, a combination of that. So anything beyond this thing, a skin rash, if the lips are being swollen, the tongue is being swollen, you're drooling saliva, that's the time to call 911. If the blood pressure is running low, anaphylaxis kicking in, that is beyond the scope of home remedy or home or over-the-counter medication. Sometimes you need epinephrine shots. Sometimes you need to be on a ventilator to protect the airway if the airway is getting swollen. Sometimes you need medications to raise the blood pressure up, which means ICU and life support. So the treatment plan is very vast depending upon how severe the allergic reaction is.
Okay, the last question for today is are there any home remedies for very preliminary, less frequent asthma condition?
Um, the home remedy, I mean, I'm somebody who's a huge fan of honey and lemon. If you have a little sore throat, use it. But per se, home remedy is just prevention. And we don't go just by the nutrition and by alternate medicine per se. At least I don't know about you, Dr. Sheikh. But yes, avoiding the allergens, keeping your house clean is the best way. Um, Avoid the triggers, avoid food that you could be sensitive to. Now there are certain chemicals in processed food like sulfites which have shown to have significant can cause significant bronchospasm, so avoid that. But as far as like what to take if you have an asthma attack, don't take chances. Use your inhaler, talk to your healthcare provider. That's the safest way to go.
Excellent. Thank you so much this was an amazing, enlightening presentation, Dr. Sheikh, Dr. Ali. Thank you for giving us your time, and thank you to the entire audience for such a great discussion. And with that, I'm going to end the session over here. Please watch out for messages from IMI for future sessions. Thank you so much. Have a wonderful weekend. Bye bye.
Thank you.
Thank you.